The next talk would be on developing transplant programs around the world, importances of health systems, building blocks. May I invite the speaker, Dr. Vivek Ananja. Now I invite the chairpersons for this talk, Dr. Pankaj Shah, Dr. Narayan Prasad, Dr. Iqbal B, and Dr. R.K. Yadav. Over to the chairpersons.
Thank you very much, organizing committee and Dr. Vivek Pute for this opportunity to chair this so important session. Professor Vivekanand Jha does not need any introduction. He is the immediate past president of International Society of Nephrology. I do not want to waste too much of the time on his introduction. So over to you, Professor Jha. You can start your presentation.
Thank you very much, Professor Prasad. I would like to start by thanking the scientific committee and the organizers of the Indian Society of Organ Transplantation for inviting me. I hope I will be able to share my screen because I tried a couple of times and it was kind of shut down. So hopefully you can see my screen, right?
Yes, sir.
All right, good, thanks. So the topic that I've been assigned is how to develop transplant programs around the world and making sure that we pay attention to health systems building blocks. So on the bottom, you can see the logos of the two organizations that I work with, which is the George Institute for Global Health. It's the Healthcare Research Organization, and Imperial College London, with which I have faculty appointment. So we know for sure that within the available kidney replacement transplant modalities, kidney transplantation should be the highest priority, which is shown by this triangle and the various sections of this triangle, in which each section of the various portions of the triangle represents the value for money that each intervention brings so far as management of patients with chronic kidney disease is concerned. The top part here, shows the treatment options for management of end-stage kidney failure, and there you can see that the size of kidney transplant part is bigger than the two dialysis modalities, which means it should be the highest priority because it brings best value for money, both in terms of the number of lives gained and the quality of life as well. In nearly all studies done around the world, survival of people with kidney failure is better with kidney transplantation than dialysis for all ages, all causes of kidney disease, and people with all kinds of comorbidities. Similarly, in terms of quality of lives, almost all studies have shown that quality of life is better with kidney transplantation than dialysis. And here you can see this graph, which shows you the cardiac events in terms of hospitalizations and actual events, and in the various domains of the short form health survey, which is also called SF36. Almost every single domain is on the side that favors transplantation. The third important consideration, especially for us in India, is the cost. We know that in many countries, hemodialysis is much more costly than the first year of kidney transplantation. In some countries, you can actually do hemodialysis for lesser cost than the first year of transplantation, but as the number of years lived with this modality accrue, the cost advantage of transplantation keep getting better and better. We all know that in all regions, for sure, hemodialysis is much more costly than maintaining a kidney transplantation over the period of several years. Despite the fact of all this overwhelming superiority of transplantation, we know that there are about 5.3 million people living on dialysis in 2017, whereas the number of kidney transplants that were performed is less than 100,000 according to Global Observatory for Donation and Transplantation. And each kidney here represents 100,000 or 1 lakh treated cases of kidney failure. And you can see the number of people who have received kidney transplantation compared to those who are not on kidney transplantation here. This simply highlights the shortfall in the need and what we have available. We know that the prevalence of kidney transplantation or the use of kidney transplantation as the optimal modality of kidney replacement therapy around the world varies. And this particular slide taken from the US annual data report ranks countries in terms of their utilization of kidney transplantation as the preferred modality. And you can see that the countries that do the best here are Scandinavian countries, Norway, Finland, Sweden, followed by United Kingdom, Qatar, and then come a few other Middle Eastern and Eastern European countries, followed by Canada, and so on and so forth. And if you placed India here, India will come even below all the countries that are shown here on this particular slide in terms of the proportion of people treated with kidney transplantation. And India is not alone in this instance or in this regard. You can see that there are many, many countries where the number of people who receive kidney transplantation is much less than what they need. You can see these countries colored in these different shades of blue. The darker blue the color is, the more prevalence of kidney transplantation that country has. And the lighter blue indicates lower prevalence of kidney transplantation. And you can see that India is one of the lightest blue. And the countries that are colored in gray means that there is no data or there is no transplant program in those countries. Here, according to the best estimates, is the current state of organ transplantation in India. And this was based on a survey of nephrologists and various other transplant surgeons that we and a few other colleagues of mine conducted for a paper that we published in Transplantation earlier this year. You can see the huge gap between the estimated need of kidney, liver, heart, lung, and pancreas, and the current number that we are able to do. Even though in terms of the actual number of kidney transplantation carried out in the world, India would be perhaps second or third in terms of the total numbers, but if we normalize it for population, we'll be right at the bottom. And you can see the number of registered centers that do transplants for these various organs in the third row, followed by cost and how many of these centers are in public hospital and the possible organ source that is used. This particular slide shows you the density of kidney transplant centers in India. And here you can see that the darkest blue is best, followed by green, followed by orange, and followed by dark brown and red. So dark brown and red means low density of kidney transplant centers, and green and light blue means high density of kidney transplant centers. And you can see uniformly that southern Indian states and a few states in Western India and a couple isolated in Northern India have reasonable density of kidney transplant center, even though even this density is much less than what you would expect in Europe, etc. So then in summary, transplantation versus dialysis or kidney failure, if this game was to be played, transplant is associated with less mortality, less cardiovascular disease, better quality of life, and is less expensive for all ages, all causes of kidney disease, and all comorbidities. Then the question might be, why is transplantation the main treatment for kidney failure in so few countries worldwide? It should be the main treatment one would expect. And there the answer is in the form of the WHO health systems building block and how many of these countries score relatively poorly on their performance in these health systems building blocks. And these are the health system building blocks shown here on the left: service delivery, workforce, health information systems like registries, availability of medical products, which means drugs, vaccines, and technologies, financing, and leadership and governance. Eventually, if all of them are working together, it will lead to improved health in terms of level of healthcare and equity. It will be responsive to the needs. It will lead to social and financial risk protection, and the efficiency of health systems will improve, which are all linked to access, coverage, quality, and safety. The underpinning principles of the health systems is solidarity, social justice, universal access, multi-sectoral action, community participation, and consistency with the values and preferences of the society in which these programs are implemented. And this is something which you saw earlier, so I won't go into it again. What we looked at now using data from the Global Kidney Health Atlas, which is an exercise that is carried out by the International Society of Nephrology to assess the readiness of different countries around the world in their ability to provide kidney replacement therapy. And this is what we found when we compared different parts of the world: Africa, Central and Eastern Europe, North America and Caribbean, Middle East, newly independent states and Russia, Latin America, Oceania and Southeast Asia, South Asia, in which we Indians live, and Western Europe. And there you can see the various domains which were either generally available, generally not available, never in the gray section, and not available in yellow. And when you looked at transplantation in terms of availability of multidisciplinary teams, because multidisciplinary teams are critical for a management of transplant, this slide shows you the great variation that exists in different parts of the world, with Middle East for some reason doing very well, and Western Europe also doing reasonably well, but other parts of the world, such as Africa, are not doing so well here. So then, when you go on to look at the funding models for transplantation, once again, you see great variations. And here in South Asia, you see in India especially that there is a big mixed public-private funding model, etc. And many patients end up paying out of their own pocket, which is shown here in the yellow section. Availability of standard organ procurement frameworks, again, variable in different parts of the world. Africa faring really poorly, and South Asia is not doing very well either, because most of these standard organ procurement frameworks are not available generally in many parts of South Asia. So then where do we go from here if we have to improve these situations? I know that we have only a few minutes to talk about it, so we can't really discuss any of these things in detail. So I would leave you with some of these thoughts, and I think we need to have more debate on these topics for us to make progress, because we need to focus on a number of these aspects, and I've listed 8 of them here. But we have to start with legislation, credentialing, and regulatory oversight. That needs to become robust. We cannot do anything unless we have a very solid, sustainable financial model. The workforce that needs to provide transplantation needs to be improved. We all understand that. We need to develop better interventions and simplification of procedures and standardization of various procedures that are used in kidney transplantation. Laboratory methodology, including, for example, measurement of immunosuppressive drug levels and availability of facilities to read kidney biopsy should become available. Medication should be uniformly available to people who need them. We need to have universal protocols, and we need to stick to those protocols. And we need to report our results, not only for the donors, but also, not only for the recipients rather, but also for the donors, to see how we are doing. Can this be done? Yes, it can be done, and there are examples from around the world. One such example to which I would like to draw your attention is the Sister Transplant Center program, which has been established by the International Society of Nephrology and the International Transplantation Society, which links up centers in developing countries with centers in developed countries to help them learn from each other and hopefully improve development of transplant programs in the developing countries. And here is just an example to show the success of one such program, which is in Vietnam, where a sister center relationship was able to set up a pediatric kidney transplant program. And this is the first pediatric kidney transplant recipient you can see here. And you can see the education ambassador, you can see the smile on the face of the ambassador. But what the ambassador had to say, that the biggest reward for her was the smile on the face of the transplanted patient. So there are smiles all around, and it should make us proud also that it is all possible. So I'm going to stop here. I hope that I've been able to give you a whistle-stop tour of how the health systems building blocks work and how we can use the health systems building block approach to develop organ transplant programs around the world. And I'm happy to take any questions.
So thank you very much, Professor Jha, for this lucid presentation. Actually, this was very much informative. And you have covered almost all aspects where there is need of transplantation, and more centers and more laboratories and more trained manpower workforces. So that was very important. Can you, sir, highlight a few points, India specific, whether there is so much disparity from one part of the India than the other part of the India, and what we can do for that? Some India specific problems.
So not really a problem, but I would say some areas in which we can do better. The first thing is certainly to ensure that transplantation is treated in the same way or with the same degree of sensitivity that dialysis has been for the last few years. We know that people are able to access dialysis free of cost through the National Health Mission programs. We need to lobby with the governments to ensure that transplantation receives the same priority. I know that there are a number of state governments that are actually taking this step, but we need to make this a right for all patients all across the country, not only a few states. And I have to mention the states of the names of states of Tamil Nadu, Kerala, Gujarat, Andhra Pradesh, Telangana, etc., that have been proactive about this. But we need to take this to all states in the country. That's number one. Second is we have to grow transplant programs in the public sector. That's really critical. While private sector has been filling the largest need right now in the country, we know that a huge proportion of our patients will be unable to get transplantation if it grows only in private sector. And similarly, the cost of transplantation will be relatively high. And so if we have to fund transplant through taxpayers' money, it should be done through public sector so that people who are otherwise unable to access it, are disenfranchised from the current healthcare system, also feel able to do it. The third, of course, is to grow our organ donor pool. There has been a lot of conversation around it, but we need to do more to make sure that it becomes again equitable, and it becomes it becomes a system in which people everyone feels that they stand a chance of being able to gain an organ if they need it from that organ system. There are a number of other things that we can do, but I'll stop here. I would also really stress on the need for delivering standard quality assured healthcare in terms of access to immunosuppressive therapy and the protocols that we use to work up our patients and treat our patients with regard to different aspects of transplantation. But I'll stop here.
May I request the chairpersons to wind up the session?
Okay, Dr. Pankaj sir, you have any comment?
I think he is not live.
Dr. Ashok?
R.K. Yadav.
Dr. R.K. Yadav?
Sir, excellent presentation, and there is always so there is disturbances in demand and supply in India. I think we should more focus on cadaveric transplantation. And regarding funding, sir is rightly said, there is some problem in funding. Otherwise, nice presentation.
So thank you, Professor Jha. Thank you,
Professor
for this
Jha, can I ask you a question? Professor Jha, can I ask you a question?
Yes, please.
It's Krishna Menon here from United Kingdom. That was a really nice talk. My question is, very much along the lines of what we've done in liver transplantation. We have set up what we call a medical training initiative program, where we take trainees from India, train them in the United Kingdom to go back and develop the programs in the public health sector hospitals. This is exactly what you were talking about, developing the program in the public health sector hospitals. Would you be interested in doing something similar for kidney?
Professor Jha, are you there to comment on?
I think
Probably Professor Jha has...
sir is disconnected.
Professor Jha has already left probably, and actually you have rightly pointed out that we must have such kind of, there are many liver transplant surgeons who have been trained in the UK or now working in India. And now India has many independent transplant center, even liver transplant centers across. So definitely there should be mutual approach to get the mutual benefit from each other. So that is always there. So thank you everyone. Thank you for joining this meeting. Thank you everyone. Over to you, organizer.